Chapter 5, Unit 5, Mental and Physical Health. Part 5.1, Introduction to Health Psychology. What is health psychology anyway? All right, let's set the scene. Imagine you've got a huge exam coming up. Maybe, hypothetically, something like the AP psychology exam, and suddenly you notice your stomach is in knots, you can't sleep, and you've had a cold for 2 weeks that just won't quit. Coincidence? Health psychology says absolutely not. This field sits right at the intersection of your mind and your body, and its core argument is one of the most important ideas in all of modern medicine. Your psychological state directly influences your physical health, and vice versa. Health psychology is the subfield of psychology that examines how biological, psychological, and social factors influence health, illness, and healthcare behavior. You'll sometimes see this framed as the biopsychosocial model, which is a term you absolutely need to own going into the AP exam. The biopsychosocial model replaced the older 8-biomedical model, which treated the body almost like a car. Something breaks, you fix the part, end of story. The biopsychosocial model says that's far too simple. Your genetic biology, your thoughts and emotions, your relationships, your culture, your socioeconomic status, all of these gears turn together and collectively determine how healthy you are. The biopsychosocial model in action. Here's an analogy that tends to stick. Think of your health like a 3-legged stool. One leg is biological, your genetics, your immune system, your neurochemistry. One leg is psychological, your stress levels, your coping style, your beliefs about your own health. The third leg is social, your support network, access to healthcare. That's why someone with excellent genes but crushing loneliness and chronic stress can still develop heart disease. The stool needs all 3 legs. A common AP pitfall here is confusing the biopsychosocial model with the biomedical model. If an exam question describes a doctor who only looks at lab results and ignores a patient's anxiety or social isolation, that doctor is operating from a biomedical perspective. The biopsychosocial approach would have that doctor also asking, is this patient under chronic stress? Do they have people at home who support them? Do they feel in control of their own health? Stress, the central character. No discussion of health psychology gets very far without stress walking through the door. Stress is essentially your body's response to any demand or threat, real or perceived. The researcher Hans Selye gave us the modelGeneral Adaptation Syndrome, GASAZE, a 3-stage model describing how the body responds to prolonged stress. Stage 1 is Stage 2 is resistance, where the body tries to adapt and cope with the ongoing stressor, maintaining a high level of physiological readiness. Stage 3 is exhaustion, where your resources are depleted and you become vulnerable to illness and breakdown. A mnemonic worth keeping in mind over alarm resistance exhaustion. Selye's gas model is a frequent guest on the AP exam, and questions often ask you to identify which stage matches a described scenario. If someone has been working brutal hours for months and suddenly gets sick right after a deadline passes, that's exhaustion. Their body held on as long as it could and then finally collapsed. Stress and the body, the physiology you need to know. The physiological pathway that connects stress to illness runs largely through 2 systems. First, the sympathetic nervous system triggers that immediate fight or flight alarm response. Second, over the longer term, the EHPA axis that's the hypothalamus pituitary gland, and adrenal glands working in sequence releases the hormone cortisol. Cortisol is helpful in short bursts, sharpening your focus and managing inflammation. But Chronically elevated cortisol is genuinely damaging. Suppresses the immune system, disrupts sleep, promotes fat storage around the organs, and impairs memory. This is the biological chain that explains why chronic stress literally makes people sick. Psychologist Shelley Taylor contributed the idea that women under stress may show a different pattern than classic fight or flight. One she called S03E05, a tendency to nurture others and seek social connection rather than confronting or fleeing the stressor. This is a nuance the AP exam has tested, so don't assume fight or flight is the only stress response in the literature. Promoting health and preventing illness. Health psychology isn't just about how things go wrong. It's also deeply interested in what keeps people well. Concepts like LEA, health-promoting behaviors, exercise, balanced nutrition, adequate sleep, avoiding substance abuse sit alongside psychological constructs like self-efficacy, a term from Albert Bandura, meaning your belief in your own ability to execute the behaviors needed to achieve a goal. High self-efficacy predicts better health outcomes because people who believe they can make changes actually do make them. Someone with low self-efficacy might know smoking is harmful, but feel powerless to quit it. Perceived control is a related idea, the sense that you have agency over what happens to you. Research consistently shows that people who feel in control of their health behave more proactively and recover from illness more effectively. This connects back to the stool. Psychological factors aren't just abstract. They translate into concrete, measurable health outcomes. Now that we've established the foundation of health psychology, the biopsychosocial model, the stress response, and what it means to promote wellness, we're ready to move into one of the most important concepts the AP exam will test you on, the specific nature of stress, how psychologists measure it, and the powerful ways it shapes your mind and body over time. Part 5.2, Positive Psychology. What is positive psychology anyway? All right, let's talk about something that might feel a little different from the rest of psychology because for most of the field's history, psychologists were almost exclusively focused on what goes wrong with the human mind. Depression, anxiety, trauma, disorder, after disorder. And that work matters enormously. But in the late 1990s, a psychologist named Martin Seligman stood up as president of the American Psychological Association and essentially asked, why don't we study what goes right? That question launched the field of positive psychology, the scientific study of human flourishing, well-being, and the strengths that allow people and communities to thrive. Think of it this way. Imagine medicine only studied disease and never studied what makes people healthy. You'd know a lot about sickness and almost nothing about vitality. Positive psychology is psychology's attempt to correct that imbalance. For the AP exam, you need to understand that positive psychology is not just think happy thoughts. Think. The PERMA model. Seligman eventually organized the core elements of well-being into a framework you absolutely need to know. The PERMA model, each letter stands for one pillar of a flourishing life, each positive emotions. Things like joy, gratitude, serenity, and hope. Ali is for engagement, being so absorbed in an activity that time seems to stop. Rizit is for relationships, having meaningful social connections with others. Is for meaning, feeling that your life is part of something larger than yourself. And and if someone describes a musician who loses track of time while playing guitar, that's engagement. If someone volunteers at a shelter because they feel called to help, that's meaning. Flow, that losing track of time experience, has a technical name coined by psychologist Emiri Mihaly Csikszentmihalyi. Pronounced roughly, Csikszentmihalyi. Yes, that's a real tip for remembering it. Emery flow is a state of complete absorption in a challenging but manageable task, where your skill level is perfectly matched to the difficulty of what you're doing. Too easy, and you're bored. Too hard, and you're anxious. Right in the middle, you're in flow. Picture a rock climber on a route that's just at the edge of their ability, fully present, not thinking about dinner or their phone, just climbing. That's flow. Csikszentmihalyi found that people report their highest levels of satisfaction and happiness not during leisure or relaxation, but during these deeply engaged states. This one surprises a lot of students, and that's exactly why it shows up on the AP exam. Learned helplessness versus learned optimism. Here's where Seligman's earlier work connects beautifully. Before founding positive psychology, Seligman studied learned helplessness, the condition that arises when an organism repeatedly faces uncontrollable negative events and eventually stops trying to escape them, even when escape becomes possible. You've probably covered this in the learning unit. A dog shocked repeatedly with no way out eventually just lies down and accepts the shock, even when the researchers opened a door. Seligman flipped this idea to develop the concept of learned optimism. Just as helplessness can be learned, so can a more optimistic explanatory style, the habit of attributing bad events to temporary, specific, and external causes rather than permanent, pervasive, and personal ones. Someone with learned optimism who fails a test thinks, I didn't study enough for this exam. Temporary and specific. Someone with a pessimistic style thinks, I'm just not smart. Permanent and personal. The AP exam may give you a scenario and ask you to identify the explanatory style at work, so practice distinguishing between those dimensions. Character strengths and virtues. Seligman and colleague Christopher Peterson also developed the S03E05 classification of character strengths, a catalog of 24 strengths organized under 6 broad virtues like wisdom, courage, humanity, and transcendence. You don't need to memorize all 24, but you should know that positive psychology takes human strengths seriously as real, measurable psychological traits, not just soft personality quirks. The idea is that therapy and education can be as much about building strengths as about fixing deficits. Common AP pitfalls. A few things trip students up here. First, don't confuse positive psychology with positive thinking. They're not the same. Positive psychology is empirical science. Positive thinking is a cultural attitude. Second, remember that happiness in positive psychology is not just pleasure. It includes engagement and meaning, which sometimes involves struggle and difficulty. A meaningful life is not always a comfortable one. Third, students sometimes mix up flow and positive emotions as if they're the same perma-component. Flow lives under engagement, not the P for positive emotions. Also keep Seligman's name attached to both learned helplessness and positive psychology. The AP exam occasionally tries to trick you by making it seem like those concepts come from different researchers. Bringing it together, positive psychology gives us a scientific vocabulary for the best of what it means to be human, and it also gives the AP exam a rich field of concepts to test. Know your PERMA, understand flow, and be able to spot learned optimism in a scenario, and you'll be in great shape. Speaking of the full picture of mental health, let's move forward and explore how stress, one of the biggest threats to well-being, actually works in your body and mind. Part 5.3, explaining and classifying psychological disorders. All right, settle in because this is one of the most fascinating and honestly, one of the most human topics in all of AP psychology. We're talking about psychological disorders, what they are, how we explain them, and how we organize them into categories we can actually work with. Let's start from the very beginning. What makes a behavior disordered? Here's a question worth sitting with. How do we decide when something crosses the line from quirky to clinically significant? Psychologists use a framework sometimes remembered by the shorthand, the 3D, this estrid, dysfunction, distress, and deviance, EASE. Some textbooks add a fourth, danger, Dysfunction means the behavior interferes with daily life, work, relationships, basic functioning. Distress means the person is suffering because of it. Deviance means the behavior falls outside what the culture considers normal or acceptable. And danger refers to potential harm to oneself or others. Now here's a critical AP pitfall. None of these criteria alone defines a disorder. Plenty of behaviors are deviant but not disordered. Think of an eccentric artist or a competitive extreme athlete. You need the full picture. The AP exam loves to give you a scenario and ask you to identify which criterion applies. So practice applying all 3 or 4 together. Perspectives on psychological disorders. Now, how do we explain where disorders come from? This is where the major psychological perspectives each stake their claim. Think of them like rival teams all trying to explain the same mystery. The biological perspective says disorders are rooted in the body, genetics, brain chemistry, neurotransmitter imbalances, or structural brain differences. Someone with depression, from this view, might have lower serotonin activity. The psychoanalytic, psychodynamic perspective traces disorders back to unresolved unconscious conflicts, usually from early childhood. The behavioral perspective argues that disorders are learned through classical conditioning, operant conditioning, or observational learning. A phobia, for instance, might have been classically conditioned by a scary experience with a dog when you were 6 years old. The cognitive perspective focuses on distorted thinking patterns. A person with depression may catastrophize small setback. The humanistic perspective suggests disorders arise when people are blocked from self-actualization or lack unconditional positive regard. But here's the big idea the AP exam wants you to really internalize. Modern psychology doesn't pick just one team. Instead, we use the Biopsychosocial model, which recognizes that disorders emerge from an interaction of biological factors, genetics, brain chemistry, psychological factors, thoughts, emotions, learned patterns, and social, cultural factors, relationships, stress, socioeconomic status. Think of it like a recipe. It's rarely just one ingredient that causes a disorder. A person might have a genetic vulnerability to anxiety, combined with a stressful home environment, combined with learned avoidance behaviors. That recipe produces the disorder. The biopsychosocial model is the gold standard in contemporary psychology, and the AP exam will test whether you can apply it to case studies. The DSM, Psychology's Diagnostic Handbook. So once we decide something is disordered, how do we classify it? Enter the DSM, the Diagnostic and Statistical Manual of Mental Disorders, published by the American Psychiatric Association. Think of it as psychology's official rulebook. The current edition is the common AP pitfall here is confusing the DSM with a treatment guide. It's not. It's a classification and diagnosis tool. It tells you what someone has, not how to treat it. Also worth knowing, the DSM has evolved dramatically over time. Homosexuality, for example, was classified as a disorder in earlier editions and removed in 1973. A reminder that diagnosis is partly a cultural and historical process, not just a purely objective science. Why classification matters and its limits. Classifying disorders is enormously useful. It allows clinicians to communicate clearly, researchers to study disorders systematically, and insurance companies to authorize treatment. But there are legitimate criticisms. The biggest one is the B-list label effect. Once someone is labeled with a disorder, people, including the person themselves, may start interpreting all their behavior through that lens. Rosenhan's famous pseudopatient study illustrated this powerfully. When sane people got themselves admitted to psychiatric hospitals, the staff interpreted their normal behaviors as symptoms of their diagnosis. Another criticism is that the categories can feel artificial. Mental disorders exist on a spectrum, and the line between disordered and not disordered is sometimes fuzzy. The DSM tries to handle this by specifying that symptoms must cause clinically significant distress or impairment. But in practice, that judgment call requires human expertise and cultural sensitivity, putting it all together. So here's your mental map. A psychological disorder involves dysfunction, distress, deviance, and sometimes danger. We explain disorders through multiple lenses: biological, psychological, social, and the biopsychosocial model integrates all of them. We classify disorders using the DSM, which is a diagnostic tool, not a treatment guide that evolves with our cultural and scientific understanding. Know those three pillars cold, and you'll be ready for whatever scenario the AP exam throws at you. Up next, we'll start diving into specific categories of disorders: anxiety, mood, dissociative, and more, so you can see exactly how these frameworks play out in real diagnoses. Part 5.4: Selection of categories of psychological disorders. What makes something a disorder? Let's start with a question that sounds simple, but is actually pretty profound. When does a quirky personality trait cross the line into a psychological disorder? The AP exam loves to test whether you understand this distinction, so let's nail it down right now. Psychologists generally define a psychological disorder as a pattern of thoughts, feelings, or behaviors that is deviant, distressful, and dysfunctional, sometimes called the 3Ds. Deviant means the behavior significantly departs from what a given culture considers normal. Distressful means the person is suffering because of it. And dysfunctional means it interferes with everyday life, work, relationships, basic functioning. A helpful mnemonic here is much of the 3D vision. You need all three dimensions to see the full picture of a disorder. One common AP pitfall is assuming that something weird automatically qualifies as disordered. Plenty of eccentric behaviors are neither distressing nor dysfunctional. The student who collects thousands of vintage erasers isn't disordered unless that habit is genuinely disrupting their life. Anxiety disorders. Now let's tour the major categories. Think of your brain as a smoke detector. In a functioning home, the alarm goes off when there's actual danger. In anxiety disorders, that alarm is either too sensitive, going off constantly, or stuck in the on position even when the house is perfectly safe. Generalized anxiety disorder, or GAD, is your classic overactive alarm, persistent, excessive worry about a wide range of everyday things lasting at least 6 months. It's not about one specific trigger. It's a low hum of dread about everything from finances to whether you left the stove on. Phobias are different. They're a hyper-specific alarm. A specific phobia is an intense, irrational fear of a particular object or situation, like spiders or heights. Social anxiety disorder deserves special attention on the AP exam because students often confuse it with shyness. Social anxiety is debilitating fear of social situations where you might be judged or embarrassed, not just butterflies before a big speech. Panic disorder involves sudden, unexpected panic attacks, surges of terror with physical symptoms like racing heart and shortness of breath, along with persistent worry about having more attacks. The attacks themselves are terrifying precisely because they feel so physical. Many people believe they're having a heart attack. Depressive and bipolar disorders. If anxiety is about too much activation, depressive disorders involve a crash of emotional energy. Major depressive disorder is characterized by at least 2 weeks of depressed mood or loss of interest in almost all activities, accompanied by changes in sleep, appetite, energy, concentration, and sometimes thoughts of death. The AP exam often asks you to distinguish sadness, a normal human experience, from clinical depression, which is persistent, pervasive, and impairing. Bipolar disorder sits in a different category entirely. Imagine a mood thermostat that swings wildly from the crushing lows of depression to the elevated, expansive highs of mania. During a manic episode, a person may feel euphoric, need very little sleep, speak rapidly, and make impulsive decisions. Bipolar I involves full manic episodes. Bipolar II involves less severe hypomanic episodes paired with depressive episodes. Don't mix these up on the exam. Schizophrenia spectrum disorders. Schizophrenia is one of those terms students often misuse, and the AP exam will test whether you know what it actually means. Schizophrenia is not split personality. That's a common misconception, and refers instead to dissociative identity disorder. Schizophrenia involves a disconnection from reality marked by positive symptoms and negative symptoms. Positive symptoms are things that are added to experience hallucinations, most commonly hearing voices, delusions, false fixed beliefs like believing you're being monitored by the government, and disorganized thinking. Negative symptoms are things that are taken away: flat affect, social withdrawal, poverty of speech, a memory trick. Positive equals plus S03E05 something added. N- Negative equals minus S03E05 and something removed. Dissociative and personality disorders. Dissociative disorders involve a disconnection from memory, identity, or consciousness. Dissociative identity disorder, DI, the actual split personality, involves the presence of two or more distinct personality states and is often linked to severe childhood trauma. Students frequently confuse DI with schizophrenia, so make that mental note now. Personality disorders represent enduring, inflexible patterns of behavior that cause distress or impairment. The AP exam most commonly references antisocial personality disorder, characterized by a persistent disregard for others' rights, lack of empathy, and often manipulative or deceitful behavior. Importantly, antisocial personality disorder is not synonymous with being introverted. Antisocial here means working against social norms, not simply preferring solitude. OCD and trauma-related disorders. Obsessive compulsive disorder involves intrusive, unwanted thoughts, obsessions that drive repetitive behaviors or mental acts, compulsions performed to neutralize the anxiety. The rituals provide temporary relief but ultimately reinforce the cycle. Post-traumatic stress disorder, or PTSD, develops in some people following exposure to a traumatic event. It's characterized by intrusive memories, flashbacks, avoidance of trauma-related stimuli, negative changes in mood and cognition, and heightened arousal. PTSD is not a sign of weakness. It's the brain's threat detection system being recalibrated after an overwhelming experience. Keeping it all straight. The DSM-5, the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, is the reference book psychologists use to diagnose all of these conditions. Think of it as the field guide to psychological disorders, organizing symptoms into recognizable categories to ensure consistent diagnosis across clinicians. With a solid map of these disorder categories in hand, you're ready to explore how psychologists actually treat them, which is exactly where we're headed next. Part 5.5, Treatment of Psychological Disorders. The big picture. Why treatment matters, all right? Let's talk about something that touches nearly every family in some way: the treatment of psychological disorders. Think of this section as the what do we actually do about it chapter. You've spent time learning how disorders are identified and categorized. And now we're asking the next logical question. How do trained professionals help people heal? The AP exam loves testing whether you can match the right treatment to the right biomedical treatments. We'll start with the body because some treatments work directly on the brain's chemistry and structure. Biomedical treatments assume that psychological disorders have physical causes. Think of it like fixing a car's engine rather than retraining the driver. The most common biomedical approach is drug therapy, also called psychopharmacology. Antidepressants like SSRIs, selective serotonin reuptake inhibitors, work by blocking the reabsorption of serotonin, essentially keeping more of it available in the synaptic gap. A helpful way to picture this: imagine a sponge soaking up water too quickly. SSRIs slow that sponge down. Antipsychotics target dopamine pathways and are used for disorders like schizophrenia. Anxiolytics like anxiolytics like benzodiazepines calm the nervous system and are prescribed for anxiety disorders. One AP pitfall here: don't say drugs cure disorders, they manage symptoms. That distinction matters enormously on the exam. Beyond drugs, there is electroconvulsive therapy, ECT, which sounds alarming but is actually a carefully controlled procedure used for severe treatment-resistant depression. Brief electrical pulses are delivered to the brain under anesthesia. It's not the dramatic scene from old movies. It's far more clinical and, for some patients, genuinely life-changing when nothing else has worked. Then there's transcranial magnetic stimulation, TMS, a newer, non-invasive technique that uses magnetic fields to stimulate specific brain regions. Think of it as a targeted nudge rather than a full jolt. Psychological treatments, psychotherapy. Now, here's where the theoretical perspectives you've studied all semester come to life in practical, real world application. Each major school of thought has its own approach to therapy. Psychoanalytic, psychodynamic therapy, rooted in Freud's work, aims to bring unconscious conflicts into conscious awareness. Techniques include free association, saying whatever comes to mind without filtering, and dream analysis. The therapist is like an archaeologist carefully excavating buried emotional material. Modern versions, called psychodynamic therapy, are less about the ID and ego and more about how early relationships shape current patterns. If humanistic therapy, particularly client-centered therapy, developed by Carl Rogers, operates on the belief that people have an innate drive toward growth, they just need the right conditions. Rogers emphasized 3 core conditions: empathy, unconditional positive regard, and genuine in those. The therapist doesn't interpret or direct. They reflect and support. If psychoanalysis is archaeology, humanistic therapy is gardening. You create the conditions for natural growth. Behavioral therapies focus entirely on changing observable behaviors, not inner thoughts. A systematic desensitization developed by Joseph Wolpe pairs relaxation with gradual exposure to a feared stimulus. Someone afraid of spiders might start by just thinking about one, then viewing a photo, then eventually holding one, all while maintaining a calm state. This is a counter-conditioning in action, replacing a fear response with a relaxation response. A related technique, aversion therapy, pairs an unwanted behavior with an unpleasant stimulus to reduce it, like using medication that causes nausea when alcohol is consumed. Cognitive therapy targets distorted thinking patterns. Aaron Beck identified the cognitive distortion, irrational thought patterns like catastrophizing. This one bad grade means I'll fail everything forever, and taught clients to challenge and reframe them. The most widely practiced modern approach combines both behavioral and cognitive strategies into behavioral therapy, CBTI, which the AP exam considers the gold standard for many disorders. CBT is structured, goal-oriented, and has strong research support. A therapist and client working together like detectives to catch faulty thinking in the act. Group and community approaches. Treatment doesn't always happen one-on-one. Group therapy allows people with similar struggles to support one another under a therapist's guidance, which reduces isolation and costs. Family therapy treats the family as a system, because sometimes the most helpful intervention isn't just treating one person, but changing the patterns everyone is caught in together. Common AP pitfalls. A few things the exam loves to trip you up on. Don't confuse free psychiatrists who hold medical degrees and can prescribe medication with psychologists who typically hold doctoral degrees in psychology and generally focus on therapy and assessment. Also, remember that eclectic therapists draw from multiple approaches rather than strictly following one school. This is actually the most common real-world practice. And never mix up systematic desensitization with fluting. Both involve exposure to feared stimuli, but flooding is immediate and intense, while systematic desensitization is gradual. Exposure without the gradual buildup, that's the key contrast. A handy mnemonic for the major therapy types. Be careful. Have big plans: behavioral, cognitive, humanistic, biomedical, behavioral, cognitive, humanistic, biomedical, psychodynamic. Wrapping up this section. The most important takeaway here is that treatment approaches mirror the theoretical perspectives behind them. Understanding why a therapy works tells you which disorder and which perspective it belongs to. With that foundation firmly in place, you're ready to explore how researchers evaluate whether these treatments actually work, which is exactly where we're headed next.